Hi, this is Alicia Bright. This lecture is part one of the application of the concept of gas exchange to a patient with chronic obstructive pulmonary disease. Risk factors for chronic obstructive pulmonary disease. Well, the biggest one, the most common one is cigarette smoking. We hear about this all the time. It's one of the reasons it's a good idea not to smoke cigarettes. But there are also other reasons. Not everybody who has COPD is a smoker. Some people are exposed to occupational chemicals and dust. For instance, our coal miners, our farm workers, our factory workers. There are reasons why OSHA requires people to use face masks for a lot of occupations. Air pollution contributes to COPD as well. We have a higher incidence of it in cities that are heavily polluted. Some people can develop COPD after infections, severe infections, a lot of pneumonias. There is a form of COPD that is hereditary. You can't help it. You're going to get it whether you smoke or not because you've got the genes for it. And of course, as people get older, they're more likely to suffer this problem. It's a chronic problem that builds up over time. So it's really important not to have judgment about somebody with COPD. I see some nurses who sort of assume that if somebody has COPD, it's because they smoked themselves into it. And that's just not always the case. Not only that, but we need to have some compassion for people who are addicted to cigarettes. It's a tough habit to beat. My advice, don't start. Moving along. So this is a brief overview of the pathophysiology. Remember that it is it's a disease where the airflow is obstructed. There's two types of COPD, generally speaking, emphysema and chronic bronchitis. Since most people have aspects of both of those things, they're now combined, and we just call it COPD. But we're going to talk about the differences in a moment. It's not significant enough to separate the disease process. But the idea of COPD is it is progressive. It's non-reversible. People will have exacerbations where they get worse, and then they'll have times when they improve and they're better. But this is a gradually progressive, destructive process. The process is that the supporting structures of the lungs are destroyed. The air goes in, but similar to asthma, it doesn't get out as well, so you get air trapping. The bronchioles tend to collapse, and ultimately the patient's physiology, the anatomy starts to change. The blood vessels thicken, the surface area for the exchange of gases, oxygen and CO2 between the inside of the alveoli and the capillary beds around the outside of the alveoli. Those blood vessels thicken and the surface area decreases. Blebs form, potentially. This results in, and we'll talk about blebs in a minute, but this results in sort of a barrel-chested look for a patient. Some folks, you can tell they're COPD patients because of the shape of their chest. COPD is not reversible, although people can improve temporarily, and then the next bout will probably take them further. What happens is that there's a loss of elastic recoil in the lungs so that the alveoli don't contract well enough to expel air. Eventually there's mucosal edema, mucus hypersecretion, and bronchospasm. So the problem is inflammation. When noxious particles and gases are inhaled, it irritates and inflames the lining of the bronchioles and the alveoli. This creates an inflammatory response, which results in inflammation of the airways all the way through and destruction of the parenchyma. This is a chart of the pathophysiology involved. Noxious particles come in, and then you get inflammation of central airways, peripheral airway remodeling, so the anatomy actually starts to change, destruction of the parenchyma, vascular changes, and then you see the COPD pathology associated with it, such as a lot of mucus production, destruction of the cilia, the micro hairs that help protect the airway. The cilia is destroyed. The lungs can become hyperinflated because of air trapping. Air gets stuck in there, and eventually the alveoli just kind of stretch out and get destroyed. And they don't rebound as well. They don't contract as well. They're not as elastic. You can get pulmonary hypertension, actually, cor pulmonale, and there's ultimately systemic effects. We're going to go over this in a little more detail now. So on the left, we talked about the specific changes associated with emphysema. Well, this is an example of that. The air duct gets compressed, the alveoli gets stretched out and can actually collapse. I'll show you a picture of bullae in a minute and blebs, but you see these normal, on the right it's a normal air sac of the normal alveoli and the normal bronchioles. And on the left you see the compressed air duct and the destroyed alveoli. We call those joined alveoli bulla and blebs. Blebs can form on the side of the lung, the bulla forms inside the lung. What this is the walls between the alveoli have given way. And instead of having multiple small balls of places where gas can be exchanged, we instead have one big ball, and that results in a smaller surface area. There's less surface on one ball than there is on multiple balls, the alveoli being the balls. I hope that makes sense. So what are we going to see? First of all, this develops very slowly over time. If somebody has a chronic cough or chronic sputum production, dyspnea, or exposure to risk factors, we might consider this. The physician might consider that maybe they have COPD, or the nurse who's assessing them. Usually people start having trouble breathing, and that's what brings them into the doctor. They have dyspnea with exertion, or even at rest with advanced disease if they get really sick. We'll often see people doing chest breathing rather than fully, chest and abdominal breathing. These people tend to be underweight. It's hard. It takes a lot of energy to breathe, and it's harder to eat when you're breathing that hard. So these people are chronically tired. They're not getting enough oxygen. Their tissue is depleted of oxygen. And they may have paroxysmal coughing that it takes over. They can even fracture ribs with the coughing. It can be pretty severe. Your physical findings, when you assess folks, physically, you're going to hear prolonged expiratory phase of respiration. So they'll inhale, and then the exhale will be a lot longer. You can see a use of accessory muscles, so the neck muscles, the subclavian muscles, the shoulders pushing forward, intercostal muscles. Breathing can be inefficient. They can have wheezes or decreased breath sounds. If you think about it, those blebs, there'd be less airways for the air to move through. That's going to make less sound. As we mentioned, the barrel chest. People might take on a tripod position, and we'll talk about that in the next slide. This is a two-part lecture. And you might see them using pursed-lipped breathing. If you don't, we will teach it to them. So labs that you might see, people might be hypoxic. In fact, in the later stages, they will certainly be hypoxic. And we'll talk about oxygen administration to these particular population. These are one of very few populations that we actually need to be very careful with about oxygen administration. The second bullet point there talks about increased production of red blood cells. Now, why do you think that is? So we've been talking a lot about the concept of gas exchange applied to COPD. We've been talking about the ventilatory aspect, the air going in and out, and there's problems getting the air in and out, ventilation. Well, now once the air gets in, we need to load up our red blood cells with oxygen. and let the red blood cells carry the oxygen around the body. Well, if the red blood cells are not getting oxygenated enough, one of the things the body can do, so if you know that your truck is going to be half full when it's going around the route to deliver oxygen, it'd be nice to fill it up 100%, right? If the lungs are working right, we can fill up those, we give people a little extra oxygen, fill up those big red trucks, red blood cells with oxygen to deliver. But it's really hard to load up the red blood cells with oxygen when the membrane for passing that oxygen through is disrupted the way it is in COPD. So the body compensates by making more red blood cells. So if each truck is only going to be 50% more filled, maybe the thing to do is to put more trucks on the road so that you can deliver the same amount of oxygen with just using more trucks. If you can only fill each truck 50%, gosh, there you go, more trucks. So the body will actually develop a high hemoglobin concentration. People might be having a lot of having extra high red blood cell count in their body, and this is to compensate for the fact that they have a lower oxygen level. This is a chart that just compares chronic bronchitis with emphysema. And so the history of somebody with chronic bronchitis will be that their cough is productive and persistent with a lot of mucus. Somebody with emphysema will have a dry cough or mild, mild scant, clear sputum. Somebody with chronic bronchitis, they're usually obese. They're usually larger, edematous. They might be a little cyanotic. They have distended neck veins and right-sided heart failure. They might have adventitious sounds. Remember, adventitious means bad news, like wheezing and rhonchi, but the percussion would be normal. Somebody with emphysema, these folks are usually underweight, barrel-chested, prominent use of accessory muscles. You might hear distant or diminished breath sounds because of the alveoli being joined with other alveoli, and because their lungs are hyperinflated. You're going to have less tissue and more air. You'll get a hyperresonant percussion sound when you percuss the chest. The chronic bronchitis person will be hypercapnic, high CO2, and hypoxic. They'll tend to be towards respiratory acidosis. And they'll have a normal or decreased total lung capacity. The person with emphysema will have normal or mild hypoxemia and a normal pH. They will have an increased total capacity. They just can't exhale all of the capacity that they've got is usually the problem. But as I said, most people have aspects of both of these combined. Complications of COPD include acute respiratory failure. They just can't keep up with it. They might develop peptic ulcer disease. This is both because of the stress of hypoxia, the constant anxiety, and just the whole body is under stress when it's really having to work hard to breathe. And it also might be due to side effects of medications used for COPD, such as steroids. Steroid medications will predispose somebody to peptic ulcer disease. You can imagine how this person might be anxious or depressed. It's hard to breathe. And cor pulmonale is another complication of COPD. If you remember, cor pulmonale is hypertrophy of the right side of the heart. This is because the circulation in the heart is backed up, and the pressures back up into the heart, into the right side of the heart, and eventually the heart just gets stretched out. This is a late manifestation. It results, chronic hypoxia is part of this. This increase of red blood cells, as we said, is caused by the release of erythropoietin by the kidneys. This erythropoietin stimulates the body to build more red blood cells. So the other problem is that this polycythemia, all these extra red blood cells running around, this increases blood viscosity. It makes things thicker. It makes the blood actually harder to pump around, which again backs up into the blood, backs up into the heart and causes heart failure. So I'm going to talk about nursing care for COPD patients in the next lecture, in part 2 of this lecture.